Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we're going to talk about chronic kidney disease. Remember, when we say something is chronic, that means it's been going on or it's been progressing for a long time. When we talk about acute kidney injuries, we're talking about changes that have occurred relatively quickly in the kidneys. But chronic kidney disease is something that occurs over time. And as you'll see here, when we talk about the pathophysiology, the reasons why this is considered a chronic thing occurs over time because of the mechanisms by which we develop this condition are from chronic sources. So one of the primary ones I'd like you to know is diabetic nephropathy. And in diabetic nephropathy, the chronic condition is that patients chronically have hyperglycemia, right? In diabetes, we know that it's because we have sustained blood sugars that are elevated over time. It's not that we have a single episode of elevated blood sugar after we eat cake. It's that they're elevated over time. We start to develop insulin resistance, or in type 1, we don't actually make the insulin at all. So hyperglycemia over time can lead to something called non-enzymatic glycation. So what is that? Non-enzymatic glycation is a process by which proteins and lipids can actually bind together without the use of an enzyme. And the problem is this process can lead to pro-inflammatory molecules in the kidney. And what happens then is we get something called hyalinization of the afferent and efferent arterioles, ultimately leading to kidney damage. So when we talk about diabetic nephropathy, we're talking about a process by which we have damage to the vascular system, and this preferentially tends to affect the efferent arteriole. And so if we draw our attention to our image over here, we have the afferent arteriole with blood coming into the glomerulus, and the efferent arteriole is where blood actually leaves the kidney. Now, if we're having these pro-inflammatory molecules, right, from this non-enzymatic glycation occur in this hyalinization process, preferentially in the efferent arteriole, what's going to happen to our filtration? Well, damage or thickness, right, to the efferent arteriole is going to cause more of an obstruction for blood flow to actually leave through the kidney, right? It comes in through the afferent arteriole, right? Some of it is filtered through Bowman's capsule, and some of it leaves through the efferent. But if we've created an obstruction, right, we've created this hyalinization process from this non-enzymatic glycation in diabetic nephropathy, what's going to happen is the ease for blood to leave through the efferent arteriole is going to decrease. And thus, that is to say, we're going to have an increased back pressure. So normally if blood comes in here, it can go through here or here, but now this is kind of obstructed in a way, right? Some of it can leave, but not all of it. It can't leave as easily. And thus the back pressure is going to push more blood through the system going forward. Again, so if we think about it, right, if you have a system that's this wide and you have a certain amount of fluid going through it, and then that system becomes more narrow at another point, well, the pressure by which the system becomes more narrow is going to increase. So there's going to be higher pressures. And so we have a more narrow system. Higher back pressure is going to cause more to be filtered through the glomerulus itself. Now, we also have certain cells around the Bowman's capsule called mesangial cells. These mesangial cells are supportive cells, and when these cells get stressed, they tend to proliferate, and this proliferation causes glomerular basement membrane thickening and increases the extracellular matrix proteins. This leads to one of the classic findings that you can see in diabetic nephropathy, which is called a Kimmel-Still-Wilson nodule. And these Kimmel-Still-Wilson nodules are a collection of extracellular matrix proteins, and they're described as an eosinophilic nodular glomerular sclerosis in the kidney itself. So in a question stem, if they're describing to you an enlarged eosinophilic matrix in the glomerulus on microscopy, that is indicative of this Kimmel-Still-Wilson nodule. Now, another really common cause is hypertensive nephropathy, and this is due to increased blood pressure, again, chronically over time, which leads to nephrosclerosis of the arterioles, preferentially the afferent arteriole versus the efferent, ultimately leads to hypoperfusion, ischemia, and kidney damage. So what's going on there? So if we draw our attention over here to our image, right, if we have sustained high blood pressure over time, we're constantly damaging the afferent arteriole. We're constantly hitting it with too much force, too much stress on the vascular system. And so what's going to happen to that afferent arteriole? Well, if the afferent arteriole is constantly undergoing stress, right, it's going to try to increase its resilience, and it's going to thicken to what we call nephrosclerosis. It's going to become sclerotic over time. And so what happens to the renal blood flow then if we create a thickened afferent arteriole, right? It becomes sclerotic, it becomes smaller in size or constricted in size. Well, that's going to decrease the perfusion to the kidney. If this is the way that blood flow comes into the kidney, into the glomerulus, and then leaves to the efferent arteriole, if we narrow the entrance area, right, at the afferent arteriole because it becomes sclerotic over time due to the hypertension, overall our renal blood flow is actually going to decrease because it's harder for blood to actually get through the narrowed portion of the afferent arteriole. And that's why we see the decreased perfusion, ischemia, and ultimately kidney injury. So again, similar outcome, right? Kidney injury is what happens, but the process is different when we talk about diabetic nephropathy versus hypertensive nephropathy. And the third one that they like to test you on is glomerulonephritis. This is typically due to inflammatory or non-inflammatory damage to the kidneys. So this is most often going to involve some kind of autoimmune condition where they'll talk about the antibody antigen complex, which can then go bind in the kidney itself. And that can create some sclerosis as well. That can affect our filtration barrier. If these are binding in Bowman's capsule, in the arterioles, right, this is going to cause kidney damage as well. And so the pathophysiology of these mechanisms is certainly a lot more complicated than we've discussed here, but I think the key points are to realize that there are multiple different ways that we can get chronic kidney disease. Anything that causes an obstruction to blood flow to the kidney, anything that causes an obstruction to outflow from the kidney, anything that causes direct damage to the kidney itself in the case of glomerulonephritis can also lead to signs and symptoms of chronic kidney disease. Now, why is this important? Because in chronic kidney disease, we tend to see a decrease in GFR, and a decrease in GFR is going to decrease our urine production and increase our extracellular fluid volume. This makes sense to us. If we damage the kidney, right? If we damage our filtration system, we're not bringing enough blood flow to the kidney. Or if we start with increasing GFR, but subsequently decrease GFR because of continued damage, as we see in diabetic nephropathy, what's going to happen? We're going to retain more fluid. If we're not excreting our substances, we're not excreting our salt, our water is going to stay in the body as well. And that's why a lot of times with these patients, you can see these findings such as pitting edema. Sometimes they can get fluid around the heart. The reason is because our GFR has decreased. We're not filtering our substances, and thus we're not filtering our water as well. In addition to our water, we're also not excreting some other key products as well, including urea, phosphate, and various medications. And so we'll talk much more about this in terms of what we'll see in these patients, what their presentation will be like, what their diagnostics will be like. But this all comes down to the fact that in chronic kidney disease, we have damage to the kidney. We're not filtering substances as well. We have a decreased GFR. Another key one they like to test you on is the decreased 1-alpha hydroxylase. Now, 1-alpha hydroxylase is an enzyme that the kidneys produce. And that enzyme is super important because it takes inactive vitamin D and turns it into active vitamin D. So if we have less of this enzyme, why do we have less of this enzyme? Because the kidney is damaged itself. That's going to lead to less active vitamin D as well. And we know that there is a strong correlation between vitamin D and calcium. So if we decrease our vitamin D levels, what do you think is going to happen to our calcium levels? That's right. We're also going to see a decrease in our calcium levels as well. And now, to continue our understanding of the physiology, what's the body going to do when it senses a decreased calcium level? Well, remember, we have two primary hormones for balancing our calcium. We have calcitonin and PTH. PTH stands for our parathyroid hormone. PTH is going to increase in the state of low calcium because PTH is the molecule that senses, oh, hey, we don't have enough calcium in the body. We need more of it. We need to reabsorb more of it from the bone so that we have it in the serum. If we have low calcium levels because a patient has chronic kidney disease, the body's going to respond by increasing PTH. We call this secondary hyperparathyroidism, and we call it secondary because it's due to another problem. So a primary hyperparathyroidism is somebody who has a parathyroid adenoma. It's the parathyroid itself that's chronically secreting PTH. But here, the body's secreting PTH secondary to something else going on, secondary to the low calcium that it's sensing. And that's why this is a secondary hyperparathyroidism. And finally, another classic mechanism they like to test you on is that of decreased EPO. So we also know that the kidneys play a vital role in our production of red blood cells, right? The EPO molecule is something that stimulates the bone marrow to undergo a process called erythropoiesis. If we don't have enough EPO, we don't stimulate that process, we have decreased erythropoiesis as well. This is going to lead to what? It's going to lead to an anemic state in the body, or likely a normocytic anemia, although it's not always normocytic. So again, just to summarize the mechanisms here, because I know it's a lot and it's dense, the key here is that chronic kidney disease is due to a variety of different things that damage the kidney overall and lead to what? A decreased GFR. When the kidneys are damaged, some other systems are affected, right? Because the kidneys do a lot. They're not just filtration molecules. They also activate vitamin D through the 1-alpha hydroxylase enzyme. If kidneys are damaged, we're not producing enough of that enzyme unless we're not making enough vitamin D. Kidneys are also responsible for secreting EPO, which is going to stimulate our red blood cells. If the kidneys are damaged, we don't have enough of that molecule. If we don't have enough of that molecule, we don't have enough of erythropoiesis, and ultimately we develop an anemic state. So again, the mechanisms here matter because they then explain to us what kind of findings we would see in a patient and what kind of management techniques we can use for these patients as well. So I think the etiologies are going to make sense to us now that we understand these mechanisms, right? So diabetes is going to be a problem. Why? Well, we talked about the mechanism about how this can actually lead to CKD. Additionally, hypertension we talked about. Glomerulonephritis we talked about. Certain medications such as NSAIDs can produce a similar finding, and think about why that is. Because chronic use of NSAIDs can actually produce a similar pathophysiology to what we've talked about, right? Typically, the prostaglandin molecule dilates the afferent arteriole, but what is an NSAID going to do to the afferent arteriole? It's going to cause constriction, and constriction leads to what? It leads to a similar presentation of hypertensive nephropathy. It leads to decreased perfusion, kidney damage, and decreased GFR overall. And so that's why chronic use of NSAIDs can actually be bad for patients who have kidney problems, and we discourage the use of NSAIDs from patients who have pre-existing kidney disease. And finally, congenital anomalies as well, right? So PKD, polycystic kidney disease, we have a whole chapter talking about those. These can cause cysts in the nephrons and the kidneys itself. These can compress the vascular structure, which can lead to similar presentations here, decreased perfusion and ischemia, which ultimately leads to kidney damage. Now, also important to note, these patients are at an increased risk of coronary vascular disease. This is something they'd like to test you on. And that is in part due to the fact because patients who have this condition might have underlying diabetes, which is going to increase heart disease. High blood sugars chronically, hypertension is going to increase heart disease. So they can have multiple comorbidities that lead to increased coronary vascular disease. Now, when we talk about the presentation here, it's important to note this can be asymptomatic early on, but it's also going to show signs of edema due to fluid overload as it progresses, hypertension, and heart failure. And again, if you think about the mechanisms here, we talked about decrease in GFR, decreases of filtration of substances. We're going to hold on to more sodium. That's why we can see edema and fluid overload. We talked about how hypertension or high blood pressure can cause this condition, but it can also be a result of this condition because if we're not perfusing our kidneys appropriately, right, if we have decreased perfusion and ischemia, what's going to happen? We're going to get activation of the RAS system, and that's going to bring back more fluid. It's going to make the problem worse. It's going to worsen the hypertension itself. And chronically over the long term, this can lead to heart failure. Now, other presenting signs can include things like fatigue, nausea, vomiting, and pruritus. And again, the reason is because of the GFR, we're going to increase our toxic metabolites in the body. Some of these classic ones are going to be urea, phosphate, and various other molecules. Now, urea is interesting because urea is a toxic metabolite when it gets too high in the body, right? We're always producing urea. Typically, we're excreting it at a reasonable amount. But when urea gets too high, we get a lot of unique findings in the body. One of them is this pruritus, which is kind of this itching sensation that patients can get when you have a buildup of this toxic molecule. Other important presenting signs can include hematologic complications such as anemia. Why do we get anemia? We talked about the loss of EPO that the kidney normally makes. Kidney's damaged, it's not making EPO, we're going to get less erythropoiesis. We can also see an infection, right? Impaired neutrophils. So kidney damage and increased buildup of these toxic metabolites can actually impair our cells, not just the production of our red blood cells, but it can impair the activity of other cells like our white blood cells. And additionally, we can see an increased bleeding time. And this has to do with platelet dysfunction. So again, these toxic metabolites can actually alter our cells, right? Their function, their normal function. So that's why we have the increased infection risk or the increased bleeding time due to platelet dysfunction. Now, a pretty classic tricky question I'll ask you is a patient who has chronic kidney disease, right? They have the signs of uremia, the volume overload, and they'll ask you about their bleeding time. And they'll say, is the bleeding time increased or decreased? You know from this video that it's increased, but then they're going to ask you, what about their platelet levels? Are their platelet levels within a normal level? And the answer is yes. The platelets are still within a normal level. It's not that they're destroyed. It's not that they're decreased or not being produced. They're still normal, but the dysfunction of the platelets, they're not working properly. So despite a normal platelet level, we have increased bleeding time in chronic kidney disease. So keep that in mind. It's a very common trick question they like to ask you. Next, moving on to our diagnostics here. And again, if we understand the pathophysiology, we can understand the diagnostics. We have decreased GFR. We talked about this, right? The diagnosis actually requires decreased GFR for several months, particularly greater than 3 months. And so what's going to happen if we have decreased GFR for several months? We're going to get a buildup of those toxic metabolites. We're going to get an increase in our creatinine, right? We're going to get an increase in our BUN. These are substances that are typically filtered by the kidneys, but if the kidneys are damaged, they're not filtering substances appropriately, they're going to build up in the body and cause a variety of different problems. With a decreased GFR, we're going to see an increase in potassium, right? Typically, potassium is going to be excreted from the body. It's filtered, it's excreted. However, if we're not filtering things, that can build up to high levels. Why is this important? Well, significantly elevated levels of potassium can cause arrhythmias in the body, right? These can be deadly. So it's really important we're mindful and we're checking patients' potassium if they have chronic kidney disease. We also see a buildup of phosphate. Again, we talked about this earlier. Phosphate is a product that is normally excreted in the body, right? We use the phosphate we need, we get rid of the phosphate we don't need. If we have elevated levels of phosphate, this is going to contribute to our decreased calcium. And we've talked about this mechanism previously, but why is it that in elevated phosphate or hyperphosphatemia do we see hypocalcemia typically? That's right, because the molecules will actually bind together. The negative charge in the phosphate will bind and like the positive charge in the calcium, creating calcium phosphate. And that's going to further drop calcium levels. So now we have two things going on that's causing hypocalcemia in chronic kidney disease. We have the binding of the phosphate to the calcium. Why is there so much phosphate? Because it's not being excreted from the kidneys. We also have this portion up here with a decreased 1-alpha hydroxylase where we're decreasing our active vitamin D and decreasing our calcium. So there's two different mechanisms by which we're creating low calcium in chronic kidney disease. And low calcium is going to stimulate what? parathyroid hormone. Now, in the urine studies, the classic ones they'll ask you about are albuminuria, which is a protein that can be excreted through damaged kidneys, right? As the system becomes damaged, right, the filtration system becomes damaged, we'll begin to excrete more and more proteins, typically albumin. We don't normally want to see those in the urine, but in a damaged kidney, that barrier gets destroyed. It can also show waxy cast. This is a little bit non-specific, not as commonly tested, but it's something to be mindful of. We want to compare that to things that show our red blood cell cast or our white blood cell cast, right? Our white blood cell cast typically seen in pyelonephritis, our red blood cell cast, which can be seen in some types of glomerulonephritis. And then as far as the imaging goes, the first line thing, the best one to get is going to be the ultrasound. And what are you looking for? Well, patients with chronic kidney disease tend to have shrunken kidneys. And why do you think that is? Well, the reason is if we have decreased blood flow to the kidney over time, and we talked about all the mechanisms that can cause this, we have damage to the kidney, the vascular system, what's going to happen? They're going to shrink over time, right? They're going to atrophy because they're not getting the nutrients, they're not getting the blood supply, they're constantly damaged. And so on ultrasound, we can see this as small shrunken kidneys. However, we also talked about another case where congenital anomalies can cause this in PKD. What would you expect to see if somebody has polycystic kidney disease? That's right. You'd expect to see a whole bunch of cysts on the ultrasound itself. Now, when we move on to management here, the mainstay of management for chronic kidney disease is not to necessarily reverse it. It's to do symptom management. Patients who are starting to develop chronic kidney disease early on may be able to salvage their kidney function. But typically, by the time we catch chronic kidney disease, because it can be asymptomatic early on, it's progressed to a more advanced state. And so symptom management is going to include ACE inhibitors, angiotensin receptor blockers. Why? Because this can help with blood pressure. Statins, because a lot of these patients have comorbidities, right? They have high triglycerides, they have high cholesterol. This can help as well. We can encourage patients to decrease protein and sodium intake. Why? Because the body's already struggling to filter these molecules, right? So decreasing the intake of them helps the body with its ability to handle the load that it needs to actually filter. We can include things like supplementation, so vitamin D and calcium. We talked about multiple times already why patients have low vitamin D and low calcium levels. We can also include things like phosphate binders. And why is this helpful? Because the patients can develop a state of hyperphosphatemia because the kidneys are not filtering this molecule. We can also do EPO stimulators. And based on what we talked about earlier, this should make sense to us because we have decreased EPO in kidney disease. So if we get in a stimulator, we can hopefully improve our erythropoiesis. Now, in patients who are late stage, dialysis or renal transplant can be considered as well. And finally, to wrap up this video, some complications. So we already talked about one of the primary ones, which is the increased risk for coronary vascular disease. This has a lot to do with the damage to the kidneys itself, but also a lot of the comorbidities that patients can have as well. Patients are going to have an increased risk of uremic pericarditis because the increased urea levels, right, we're not filtering this substance, can actually build up around the heart and create a picture of pericarditis where patients can present with chest pain due to this. We can also see anemia due to the loss of EPO, increased infection risk due to the impaired neutrophils, and again, the platelet dysfunction due to the increased bleeding time. Some of the same ones that we talked about up here in the presentation as well. So obviously this can present in a lot of different ways. I struggle to give you a classic presentation for this because there's so many different ways. Like they can ask this question from so many different angles, but a possible presentation could be a 55-year-old patient who presents to the emergency department with a new onset of chest pain. So right away, we need to be thinking about some of the life-threatening things, right? Aortic dissection, myocardial infarction, etc. The patient goes on to tell you that the pain is worse with lying down, but actually improves a little bit with sitting in the chair and leaning forward. Patient reports their medical history is significant for hypertension, type 2 diabetes that they've had for greater than 10 years. They don't currently see a primary care physician as they've been trying to manage their blood pressure and diabetes through diet and exercise. The patient also reports fairly new onset of itching of the skin that's been going on recently as well. You decide to get a workup on this patient, and one of the things that stands out to you is their creatinine is 2.1. Their potassium is mildly elevated, and you also notice that their serum calcium is low. Well, this constellation of findings in the labs, along with the patient's history of having multiple risk factors for kidney disease, of hypertension and diabetes, along with the elevated creatinine, should indicate that this patient's chest pain is potentially a type of uremic pericarditis, plus the patient is itching as well. Obviously, you want to continue your workup to do your troponins, your EKG, all of these things, but given this clinical history, this patient likely has chronic kidney disease. They're just unaware of it because they have not seen a primary care doctor for a long time. So that's one of the ways that they can ask you this. So just a quick summary for this very long, very dense video. Pathophysiology here. The key that I want you to take from the pathophysiology is that no matter what's going on, diabetic, hypertensive, glomerulonephritis, we're damaging the kidney and we're decreasing the GFR. Decreasing GFR explains a lot of the findings that we have thereafter. We're also seeing damage to other things that the kidney does. So we're decreasing our 1-alpha hydroxylase and our EPO. So the kidney does more than just filter substances. And then the question is, how does a patient present if we have damage to all of these systems? Well, they can present with fluid overload because we're not filtering. They can present with fatigue, nausea due to toxic metabolite buildup, and they can present with hematologic conditions such as anemia or increased infection or increased bleeding time. Diagnostics here are really going to consider the patient's GFR in the serum labs. We talked about the increased toxic metabolites, right? Increased creatinine, BUN, potassium, and phosphate due to the decreased filtration. We talked about how the increased phosphate can play a role in decreasing calcium and how that's going to lead to secondary hyperparathyroidism. For management here, it's really based on symptom management, ACE inhibitors, ARBs, statins, things that we can do to manage the patient's symptoms, their blood pressure, their diabetes risk, and ultimately decrease their risk for heart disease. And finally, some of the complications are going to be that increased risk for heart disease, uremic pericarditis, anemia, as well as some other hematologic complications.